Okay, so I'm going to kick off. Welcome everybody to it's the second of our double data release. We're presenting data tonight that is being presented for the first time ever in the world. So it's a pleasure to have everyone here. If I can introduce the presenters and our panelists tonight. So Elizabeth Lee is an NIHR, that's our National Institute of Health Research in the UK, PhD fellow, and she's also a colorectal surgery mid-level trainee in the UK, and she's part of the Covidsurg central management team. So hi Lizzie, are you there?
Hi Neil. Great
Hi.
to be here.
Pleasure to have you. I hope you're well, and thank you for all your hard work on the from the Covidsurg central management team. Next, it's a pleasure to present Laura Bravo, who is a health data scientist in the HDR UK, which is the National Institute for Health Data Science, and she's a University of Birmingham fellow. So Laura's not a doctor. She's we're expanding into the multidisciplinary team. You're a data scientist. Hi Laura, how are you?
Hello, thank you for the invitation.
And you're in Madrid at the moment, is that right?
Yes, I've been here all the whole last year. Yep.
For the lockdown, but we've been working over distance on the machine learning angle, which has been really interesting.
Mm-hmm.
On to our panelists. Manish Chand is an associate professor of surgery at University College London and a consultant colorectal surgeon. And it's a pleasure to see you, Manish.
Thank you very much, Anil. I'm absolutely delighted and thrilled to join today. So very much looking forward to it. Thank you.
Thank you. And our other panelist is Tony Mak, who is an associate professor of colorectal surgery at the Chinese University of Hong Kong. Good evening, or is it good morning, Tony? What time is it?
It's 2:04 at the moment. So good morning, everyone.
So good morning. So it's good morning from Hong Kong. I think it's also good morning to our Australian viewers, and it's good evening as we head into Europe and further west. So our first presentation tonight is going to be from Elizabeth, from Lizzie, and that's going. It's on VTEs and surgery and SARS. And if you follow the news, VTEs are a hot topic at the moment in the news, and I think this is timely data. It's the first time it's being presented. We only finished the analysis today. So it's going to be really interesting to see how we're going to deal with this data and discuss it with our patients. So Lizzie, over to you, please.
Thank you, Anil. I'll be presenting the analysis on venous thromboembolism in surgical patients during the COVID-19 pandemic. So VTEs and especially PEs have been described as the #1 cause of preventable death in hospitalized patients. And since the beginning of the COVID-19 pandemic, there have been reports of an increased rate of VTEs in COVID patients, in particularly those ones with a more severe disease course and those admitted to intensive care. And this is of particular concern to surgical patients as they are at risk of factors that can cause venous thromboembolism, including increased immobility and altered coagulation. And they're also at risk of the opposite side of overtreatment with pharmaceutical prophylaxis, of post-operative bleeding or hemorrhage as well. So the aim of this analysis is to define the incidence of VTE in patients undergoing surgery during the COVID-19 pandemic, and also identify which features were associated with an increased risk of VTE. Our primary outcome was VTE within 30 days after surgery, and this included deep vein thrombosis and pulmonary embolism. This analysis was conducted on the Globalsurg-Covidsurg week study, which was an international prospective cohort study, which included all patients, those who had a SARS-CoV2 positive diagnosis and those who did not. This study, the participating centres collected data on consecutive patients who had an operation in their department during a 1-week period during October of 2020, and all types of surgery and all surgical specialities were included. This truly was a global study with participation from over 15,000 collaborators across 115 countries. For this analysis, we only included patients who were aged 18 years and over, which translated into over 128,000 patients' data contributing to this study. So firstly, what we did was we divided the patients up depending on their SARS-CoV-2 status into those with no SARS-CoV-2, with a perioperative SARS-CoV-2 diagnosis, which were those diagnosed 7 days before surgery and up to 30 days after, with a recent SARS-CoV-2 diagnosis, which was those diagnosed between 1 to 6 weeks before surgery, and a previous SARS-CoV-2 diagnosis, which was those diagnosed more than 6 weeks before the date of their operation. And we felt that this was a better form to better analyze what the potential effects were from SARS-CoV-2 infection. When we looked at the data and the case mix, what we saw was that this was a good representation of different types of surgery, which included 70% of our case mix being elective, 62% being major surgery, and 27% of the patients of ASA 3 to 5. So onto our results. So the overall results, what we saw was that in those without SARS-CoV-2, the rate of VTE was low at 0.5%. But those with perioperative SARS-CoV-2, we saw a VTE rate of 2.2%, so fourfold really what was seen with those without infection. And this was still high, although lower than those with perioperative SARS-CoV-2 and those with recent SARS, and also those with previous SARS, so diagnosis further and further away from the date of their operation. We also broke this down further into surgical specialities, and these are the mean rates, VTE rates, that were seen divided up into the various different specialities. And this ranged from 0% to 1.3%. And the absolute differences are relatively small, but there was some spread between the specialities. We then went on to look at what the effects of a more severe disease course, the association of a more severe disease course had with VTE rates. And we did this by firstly using pneumonia as a marker for a more severe disease course. And we then subdivided our patients once again into those who had pneumonia and those who did not have pneumonia. So firstly, I'll draw your attention to these VTE rates of those who did not have pneumonia. And once again, these have been broken down into the 4 groups I previously described of SARS-CoV-2 status. So the very left are those with no SARS at quite a low rate of 0.5%. But as you can see in the 3 columns on the right, even without pneumonia, the rate of VTE is increased in those with perioperative SARS, recent SARS, or previous SARS. Then when we look at those patients with pneumonia as well, the rates of VTE are markedly higher and notably higher as well. In particular, the group of patients who had the highest rate of VTE, which is also reflected in previous literature as well, are those with perioperative SARS and who also develop a pneumonia alongside. We then went on to put our data into a model so that we can adjust for other factors that we have previously shown to be associated with a more severe disease course and also with VTE as well. And what we find is that SARS-CoV-2 is perioperative SARS-CoV-2 is independently associated with an increased rate of VTE. And this is shown in, I'm not sure you can see my cursor, but the odds ratio column on the right, which describes how much higher this, this is compared with no SARS patients, which is the reference rate. And this is also still, this effect is still seen in those with recent SARS-CoV-2 diagnosed 1 to 6 weeks ago, but it does begin to disappear and become non-significant in those who were diagnosed more than 6 weeks ago. When we look at the other factors, so this is part of the same model, only looking at the other factors that were also contributing part of this model, we find that there are other factors that lead to also a higher risk of VTE. So they essentially contribute towards a high risk patient. So the list on the right is ranked in order of their odds ratio, and all of them are significant that is listed on the right here. Pneumonia, as we've previously discussed, is the highest risk, followed by emergency surgery versus elective surgery, major surgery versus minor, and patients of higher ASA. Malignancy and trauma are significant compared to benign surgery, and chronic kidney disease also has shown up to be significant, whereas other patient factors such as ischemic heart disease, a previous stroke or cerebral vascular disease, and congestive cardiac failure did not. Patients aged over 70 and also those patients over age 50 to 69 were also at greatest risk. And finally, general anesthesia. So there were limitations to this study and this analysis, that this is observational and we do not have data on prophylaxis. So the take-home messages are that VTE is independently associated with SARS-CoV-2 infection, and it is also associated with pneumonia. And considering that VTE is clotting and thrombotic events is a modifiable risk factor, it is something that you can consider increasing VTE prophylaxis, in particularly your high-risk patients and those with a low bleeding risk. And this can be considered but should be performed on a enacted on a patient-by-patient basis after assessing each patient individually. Thank you very much.
Brilliant, thank you. Well done, Lizzie. So a couple of just technical summaries about your presentation. So did this include patients undergoing major and minor surgery?
Yes, it did, yeah.
So I guess as we continue the analyses into the papers, there might be groups of patients, for example, undergoing major surgery who have higher VTE rates. Is that fair or?
Yes, absolutely. So within the model itself, it demonstrated that definitely emergency patients, major surgery patients had higher VTE rates, which we know and is recognized, but it did show that even after adjustment, SARS is associated with this.
So that means taking into account the different sizes of surgery and the different types of surgery, SARS remains independent.
Exactly.
And pneumonia was too, is that right?
Yes, pneumonia is also independently associated.
And what does, in the UK, we have a body called NICE who make recommendations of treatment. I don't think they've made any recommendations around surgery, but have they made any general recommendations around SARS and COVID?
Yeah, that's a really good point. So for those who are unfamiliar, it's the National Institute of Health and Care Excellence who really do look through the data and give national guidelines. And they have put out very recently, only about 2 weeks ago, guidelines around COVID patients, especially those who will be in hospital for longer than 3 days, who have moderate disease. And they say to consider intermediate prophylaxis. So in other words, higher than simple prophylaxis and higher doses. And they've based this data on the interim analysis of 3 large clinical trials who have essentially all shown that patients with COVID in hospital have, with moderate disease, have benefit from increased prophylaxis. And of course, this is interim analysis, but it is something that NICE do not recommend easily, and they would have looked over everything clearly.
Thank you. So let me come to Tony first, and then Manish for some clinical context. Now we haven't, lots of patients with SARS coming through the door hasn't, is happening in my world, and we may see more coming through. So Tony, just in general terms for elective patients, how would this data influence your practice sort of after surgery?
All right. Well, thanks. First, I'd like to congratulate Lizzie for an excellent presentation and also the collaborative for such good work. In terms of Hong Kong, at the moment, last night when I looked into the news, we had 2 local cases in total. And so far in Hong Kong, we have 11,000 cases with 200 deaths. So you can imagine this is like, in Hong Kong is actually very low in COVID. And in my hospital, the Prince of Wales Hospital, which is one of the teaching hospitals in Hong Kong, since COVID-19 has broke up last year in January, we actually ourselves hasn't operated on myself or even our general surgery patient. We haven't operated on anyone with COVID-19. Okay, so for me to give my opinion, I think at the moment in Hong Kong, we haven't really experienced sick patients who have COVID-19 who need elective or emergency operation. But certainly this data is very important because, as you know, COVID-19 is not going away anytime soon. And although there's some encouraging vaccination program, particularly in UK, I think the rest of the world are still waiting for vaccines and still having the 2nd wave, 3rd wave, 4th wave, and so on. And so for Hong Kong, we are currently our vaccination program is lagging behind a little bit, and we just had the Easter holiday, and so there might be some more waves coming through. So definitely we'll bear in mind regarding the data, and if anyone who has got the COVID-19 and required surgery will definitely bear that in mind.
So Tony, if someone, let's say in coming months, someone does turn up with a cancer and they've got a positive nasal swab, let's say they're asymptomatic, but positive nasal swab, let's say you delay them for a few weeks in keeping with our previous work, and then you decide to operate on them. Let's say it's a minimally invasive colonic resection. Knowing that they've had a positive nasal swab, would you consider enhancing or extending their thromboprophylaxis, or do you think it's enough to sit tight and monitor them?
I think it's like most definitely we take the data into account, because the current practice in Hong Kong for local Chinese population, we actually don't give low molecular weight heparin before or even after surgery. It's just in our experience, the events of pulmonary embolism or DVT is actually very, very low. As you know, we've presented data in the past in the Hong Kong local population. The BMI is roughly around 20 to 23. They're all very thin patients. We get them up and about with the enhanced recovery. So we actually experienced very, very little VTEs in Hong Kong. But definitely, it's like if someone comes in through the door who are asymptomatic with COVID-19, we've waited a little bit longer and having to do the surgery. Yes, definitely we'll put on the TEDs, we'll put on the low molecular weight heparin, and just to be absolutely sure that they'll be safe.
Thank you. So Manish, in the UK, we're probably going to see a few more patients with positive nasal swabs, and I've certainly seen a couple and delayed a couple. So questions for you, Manish, for your cancer patients, are you already giving them extended thromboprophylaxis? And if you operate on someone who's not a cancer, for example, but they had a positive nasal swab, would you do anything differently with this data?
Thank you, Anil, for the questions, and thank you again, Lizzie, for the wonderful presentation. So as you know, in the UK, we do give our patients post-operatively 28 days of low molecular weight heparin, and that has been in place for some time now. I think the study and the data that's just been presented again makes us think about timing of surgery. So it's another event to consider when, if we take on board the very informative data that was presented in the Anesthetic Journal recently about timing of surgery following COVID diagnosis, that now I'm concerned not only about the respiratory complications, but I'm also concerned now about the VTE side of things. So what we are getting, a little bit different from, I suppose, what Tony was saying, is one of the things that we're seeing now in the UK as we are trying to get patients that have been delayed from the second surge through, is that patients are now testing positive with swabs, and we're deciding on how long to delay them for. And as you've alluded to, the majority of my practice is cancer, which brings in some difficult issues about upstaging and deciding when to take that jump. Can we wait 6-7 weeks following a positive result, whether that is nasal swab or PCR? And also, if we do wait, now perhaps if we do wait that 6 or 7 weeks, we're also going to be outside that cohort that we looked in the presentation just now from a VTE perspective. So not only are we reducing the risk from a respiratory point of view, respiratory complications, but from VTE. It's a difficult balance. It's all about informed consent, I suppose, at the end of the day. And I think patients have become, certainly in our practice, a lot more involved than perhaps that we had them involved previously. And maybe that was a failing on our part previously, but certainly now where there are more options and more things to consider, I think having that conversation with patients is beneficial for all, including the clinician. And I don't mean just from a litigation point of view, but certainly from understanding what the potential outcomes are here. And these data that's been presented, I think is invaluable in making that informed choice. So certainly looking at the data today, that will be something else to consider when I'm thinking about the timing of patients in that post-COVID diagnosis phase. I mean, we very rarely need to operate in an elective setting on somebody that's had a positive swab or a positive PCR. We can delay that, but the question is how long. We got some information from the anesthesia publication, and now we're getting further information from the VTE as well about how long to delay that.
And Manish, let me flip it to the other side, which is the emergency setting. And let's say you've done a non-cancer emergency operation on someone. It might be something relatively simple, like an appendectomy. It might be something a bit more complicated, perforated ulcer. And you know, whilst in hospital, they return a positive nasal swab. I agree with what you said, that I think these are going to be individual patient decisions. What we're teasing out is that there's not going to be one set rule for these patients. But would this make you think about enhancing their thromboprophylaxis or dealing with things differently, or do you think it's too early for that? How would you approach it in the emergency setting?
So I think that's interesting, because certainly within the last week, within Europe, everybody's become a thromboprophylaxis, or certainly a clot expert, due to the concerns with with one of the vaccines. So whether your risk is whatever it is, 0.00004% of getting that, suddenly everyone becomes concerned. This is now in the popular media. So if a patient did come in tonight for an emergency operation and you started talking about clots and COVID, regardless of whether it was related to the vaccine or not, I think everyone's heightened. And it's important, I think, with data not to make knee-jerk reactions. And as you say, this data is trickling through now. It certainly makes us alert to the situation. But, are you going to double someone's length or dose of prophylaxis yet? I suppose that's what you're asking. And I think that's very difficult to do. And you would certainly need to have to make that on an individual basis until there is some formal guidance, which no doubt NICE and others will look at this information and data and make judgment on.
No, I agree. I certainly am not going to blanket change things. I guess as I look at, and I'm on call next week, so I will report back as to what happens. But if I do, what I'm thinking, how I'm going to approach my on call next week is if I do have a patient and I've got them through their day 1, day 2 bleeding risk and they return a swab, if they're overweight, they've had lots of previous clots, and they're a sitting duck for another clot, and they've got a positive nasal swab, what I'm thinking is I'll probably do a bit more for them. If it's a young patient who's had an appendectomy, who's ready to go home and they're fit and well, maybe not. But that's what I'm thinking about next week. I agree with both you and Tony that I have not got set things in my mind in terms of all or none. I'm going to apply it to the individual patient and look at their risk. And I think that's all we can, that's the best we can do with this early data for the moment. Lizzie, just very quickly, because we'll move on to Laura, but did you look at anything in patients after they've been delayed for 7 weeks, for example, and the rates? Is there any information that we'll get through on that?
Yeah, so to answer the question of how we divided those previous patients, so everybody needs to bear in mind that the rate of VTEs is still relatively low in this population, in surgical populations. And the period of time, I know it's global, but the period of time that COVID has existed, but also people have had previous COVID and have also had surgery, and also in this study is quite low. So when we actually initially looked at this analysis, we really did note that there was a higher rate of VTEs in the perioperative group. But when we looked at the smaller numbers that were in the previous group, we could not report because it was higher. The general sort of medical and healthcare population needed to be aware that this group still had a higher rate, but they were of a lower number. So to break that down very far would make it so small that is meaningless. So we broke this down into something that was reasonable clinically, into a 1 to 6 week previously and more than 6 weeks. And this is in the biggest cohort study that in COVID surgery patients. So however, it does indicate that there is a higher rate of VTE in this group of patients, and to be mindful of this.
So I'm going to just summarize, because this is a hot topic, and I'm going to answer some of the questions that have come through. We have identified in a SARS positive patient perioperatively, there is an increased rate of VTE, and in a SARS positive patient that is an older diagnosis, there is an increased rate. However, we have not linked this to any form of vaccination. We've got no evidence of any unusual locations of clots and vaccines. So I think both Tony and Manish have identified no knee-jerk reactions. Don't put the patients all your patients at increased risks by doubling thromboprophylaxis regimes or not operating. This is information that needs to be taken in context, that the overall rate of clots remains very low, but there may be a very selected group of patients who may benefit from enhanced protocols. And identifying those needs to be done on a patient by patient benefit. Okay, so that was a tricky one. That's new data. I think we're the first group in the world to be discussing that. So it's a pleasure, and thank you, Lizzie. I'm gonna move on. Could you pop the first poll up, which will just allow people to feedback some of what they'll do on the basis of the VTE data, please. I'm going to move on now to Laura. Hello, Laura, if you get your slides up. So Laura is a health data scientist at the University of Birmingham. And with her, over the last few months, we took the original COVID surge data and the question, we posed a question to Laura and said, who are the patients at risk when we operate on someone with a perioperative SARS-CoV2? And what we wanted to do is get her to inform some of our thinking and some of our consent processes around these patients. And this was Laura's research response. So Laura, I'm going to pass over to you, please. Thank you.
Perfect. Thank you very much. You can see everything fine, right?
I can, yes, you're good.
Thanks. So hello, everyone. The work that I'm going to present here is the COVID surge mortality score. I'm just going to, sorry, okay. So I just want to start by introducing very briefly some concepts about machine learning. So as a very brief description of what machine learning consists of, it is the use of algorithms to try and find patterns in the data. For example, in medicine, such patterns would be to try and see similarities and differences between patients, which is something that you have always tried to attempt, right? The thing is that now, machine learning, which is a concept from the 1950s, has become more popular than ever. And this is due to the fact that it has recently improved a lot its powers and capacities. Such improvements are a result of big technological advances, such as the increase in computer power or the recent developments of technologies such as the omics. You might have read about genomics, for instance, or other big data sets that made the use of these algorithms a necessity, and therefore ended up speeding up its implementation and development. So in essence, machine learning is a term used to group and describe different algorithms, and it is important to mention that no single machine learning algorithm is best, with different types of data requiring different approaches. So to wrap it up, I'm going to introduce a little bit some animations that you might find more revealing. So a common question in machine learning in medicine would be, how can we best try and separate different patient types? So here we have two different types of data, and our aim would be to separate patients in red from patients in blue. As you can see, both types are two-dimensional, meaning that we only have two variables, in this case, age and height. And the only difference is that you can see that in one you have data points that follow a linear pattern, and in the other one, data points that follow a more circular one, right? The thing is that if now we apply a linear machine learning algorithm, like the famous logistic regression, we will be able to accurately separate the linear pattern one, but not the circular one. On the other hand, if we then go on and apply a radial machine learning algorithm that supports vector machine, this is another algorithm type, you will then be able to separate both kinds of data perfectly. So in the end, what does this separating mean? So, in the end, what this means is that there is an area in the space that the algorithm has been able to determine to be more highly associated with a particular patient type. So for instance, here you can see that the intensity increases with how far the patients are found from the separation boundary. In essence, this means that you would be more confident in plotting a red patient here than here, or here than here. So another question would be, how can we best evaluate which algorithm has performed best? So which model has separated the patients better? So at the moment, because this is two-dimensional, which is not a reality that we will find in machine learning, you could visually attempt to do so, right? You could see that these three different modeling approaches have yielded better results than this one here. Regardless, it's always better to opt for objective metrics. And such an objective metric is something called area under the receiving operating curve, or area under the curves that you see here. You can see it named in both ways. And this, in essence, is a way in which to measure how good the separation is. An AUC of 1 amounts to a perfect separation, and an AUC of 4 amounts to the worst possible one, which is meaning that your model might as well be something done merely at chance. So, following this performance metric, we would decide that for a circular pattern data, we could choose the support the radial machine learning algorithm, and for a linear pattern one, we could choose either one of them. The thing is that we have an extra thing to take into account when evaluating machine learning models. And this is the idea that it is not only important to have a good performing model, but also one that fulfills your modeling requirements too. And what I mean by this is that you have to understand the trade-off between complexity and interpretability. So here, the radial algorithm is a powerful method, right? It was able to fit both the circular and the linear pattern, but this comes at a cost, and it is mainly that it is not straightforward to interpret. As a rule, when you have similar performances, this is the case, simple is always best. And in a case like this one, logistic regression, with its low complexity and high interpretability, would be the choice to make. So now going back to the work, hopefully with this clarification, the results are more understandable. And we could say that our aim here was to try and develop and validate a predictive score for mortality in patients with perioperative SARS-CoV2. In other words, with what I've shown before, this can be rephrased into saying that our objective was to find a model, so a variable set like before you saw age and height, and an algorithm like before you saw logistic regression, that best is able to separate alive and dead patients after 30 days. So for this, we counted with the Covidsurg cohort study, which is this international prospective observational cohort that ran on patients with positive SARS-CoV2 diagnosis in the perioperative period, so 7 days before to 30 days after surgery. Also, the study ran from the 1st of February to the 31st of July of 2020, and it included all types of surgery and surgical specialties. Also, we counted with 8,492 patients from 756 hospitals from all around the world, more specifically 69 different countries. For more details, also, the mortality was of 17.2%, as you can see here, and the surgeries were mainly major grade and emergency, with specialties being varied, but the most prominent one being abdominal surgery at a 40.9%. So now, to go a little bit into more detail regarding the methods, I'm going to present here the workflow that we followed step by step. So to start with, we divided the patient cohort, these 8,000 patients, into two sets, a derivation set and a validation set. In a derivation set, what we did was all the modeling steps and determine the final model here. Then what we did was evaluate that final model in this validation set, a group of patients that had not been involved at all in the model creation. So this split was based on time, with patients from February to June in one and June to July in the other one. The variables that we studied and introduced into the modeling were 16 different ones, and they involved descriptions of patient characteristics such as age group or sex, disease information such as if the patient had undergone a trauma or another type of problem, operation-related variables such as grade of surgery or urgency that you saw before. And then we started the modeling. So our objective was to create the simplest, best performing model. So in order to do so, what we did was first perform feature selection, where we found those variables out of the 16 that were more highly associated with the outcome. In this case, the 5 you see here. With these 5, we then combined them all together in 3 different algorithms, the 3 that you can see here. And you might recall logistic regression from the previous explanation, but we also included 2 extra ones in order to see which one best adapted to the data. In total, in between variable combination and algorithms, we assessed 69 different models. And then we ranked this model performance based on the AUC, the parameter I mentioned before, and chose the combination of these 4 features and logistic regression as our final model. So what we did with that final model was then evaluated in this validation set, and we obtained an AUC value of 0.8, that, as you might recall, was quite a good separation. So finally, this model, we deployed it, meaning that we made it available for everyone to try their own data in through an online app that I will show you in a second. But first, let me go through the final model description very quickly, as this is one of our main results. So the final model was made up of a logistic regression equation with these 4 variables. Age, preparatory respiratory support, so if the patient required oxygen, ventilation, or nothing. ASA grade, which assesses the severity of the patient, and revised cardiac risk index, which in a way is a measure of the general cardiovascular health. So as you can see, information of this information is readily available upon operation. And here in this link, I'm now going to show you a brief demonstration of how the app looks like and how it works. So you can just type this into your favorite browser, and then you should obtain this widget that comes up. And basically what you can see here is the model for you to use. On the left, you have the 4 variables that were selected in the model, and with a legend of how to introduce the values that describe your patient. And on the right, you have the prediction of the patient as determined by the model. So this patient with these characteristics, which is no respiratory support, 40 years old, a grade 1 of the ASA grade, and 0 of revised cardiac risk index is found here, and has a mole probability output of 0.02 out of 1. So this patient belongs to the lowest risk group with only a 2% of case fatality. All other patients with this low risk profile can be seen also in green. And all the threshold introduced by which we calculated the separation can be seen here in the legend. Well, I'll just play the video, because what you can see here is that as we change the variables, the risk of the patients increase, because we're making the changes of increase of age, increase of severity risk, increase of risk cardiac index, and requirement of ventilation, as would have been expected. So in a way, if we recall the explanation at the start, what we are doing here is mapping into colors the distance from the separation boundary of alive and dead patients. Being green, the ones we can be more comfortably say that would be predicted as alive, and in dark red, the ones that we would more comfortably predict as dead. So just as a final take-home message, with this work, what we have done is develop a tool for understanding individual patient risk. This will help us in shared decision-making, more specifically by giving the patient information so they can give consent with this knowledge behind, and also to the surgeon so that they can know if a delayed surgery is required. In the end, this will hopefully allow us to safely restart surgical services for those selected patients. Thank you very much.
Very well done, Laura. Thank you for taking quite a complex analysis and making it more simple for people like me. So if Dimitri's there, could you perhaps type the, or Lizzie, just type in the chat box what the link is to the risk score, please, so people can have a look. Laura, it's interesting that the specialty of the operation wasn't included in the final score. Was that intentional or part of the process? And what does that mean about the relationship between the final variables and the patient?
So yes, it was interesting that the final 4 features that made it to the model were all patient descriptions, right? And it was interesting also that specialty did make it to the feature selection process. If you recall, there were 5 features that were selected, that were the 4 final ones plus specialty. But it's true that when evaluating which came as the best performance regarding the AUC value, specialty wasn't one of them. So basically, the final model that we chose was the one that was the simplest, because it was only 4 features, but also came as top performing. So yeah, it was interesting, but it was all data driven. Mm-hmm.
So what interesting, and what I take from that is that this is probably more about the individual patient risk factors than it is about the operation that's being done. So rather than, it's not about an appendicectomy, it's about an older patient with cardiac disease who's on oxygen undergoing an appendicectomy. Okay, that's interesting. Thank you. So can I go to Manish first? Manish, some of your research is around what I call digital surgery and artificial intelligence. Do you think this is the right way to head with these type of analyses, or do you think the simpler methods are better?
Thank you, Anno. And Laura, I must congratulate you on a wonderful presentation. In particular, the way that you explained in the first few slides the differences between the different types of analysis in those diagrams, I think was absolutely fantastic. It really does make it very palatable for what is a complicated subject. And I wonder whether at some point during the last section of this, you'd be able to perhaps explain the difference as well between what you've done in the machine learning and perhaps some of the more old-fashioned risk predictor models that we would use, such as P-Possum, that work through similar statistical methods, but not quite machine learning. I think that it's important to differentiate between the two. But I know you're absolutely right. Look, you guys have the biggest pool of data when it comes to COVID and surgery. So you are privileged, thanks to the wonderful participation of everyone around the world, to have this data. And it's now, what can we do with it? And it's important that you have a multidisciplinary team that includes people like Laura, who can help really dig through and make sense of it. And this is exactly what we should be doing, because I think the traditional methods of data were useful, and we've all used P-Possum and various risk mortality calculators in our time. But I think through these big data machine learning models that Laura and her colleagues will be able to go through, I think we're going to get very accurate and personal patient risk through not only just surgery. I mean, you'd be able to do it with VTE or whatever you choose to do it with in time. So I think it's absolutely crucial, and you know, there is some degree of responsibility on the group to make sure that this data is used in that way that we can all benefit from. I will certainly be looking at the risk application and want to use that in my practice. So yes, no, absolutely love it, and I think it is definitely the way of the world and the way forward.
And then let's Laura, let's bounce Manisha's sort of earlier question to you. In surgery, we've had some risk scores around for some time, which were developed on using more traditionalist statistical techniques. You know, in your world, is this machine learning technique becoming the norm? Do you see this as the future of analysis of health data?
So I would say so, yes. In reality, this machine learning is impacting all different fields, medicine and many others. And the way that it's going, for example, you might have heard about deep learning, artificial intelligence. It is aiming to be able to give an answer to many different questions. And yeah, for what I'm seeing, yes, it's the way forward, definitely. And what you were saying about this being different to this standard statistical analysis, it has some similarities, because logistic regression, in the end, you are very all familiar with it. The differences are now more on because these algorithms, in the end, for example, logistic regression is from the start of the 20th century, for instance, right? The thing is that more algorithms are coming into practice. For example, random forest is more recent, decision trees are more recent too, convolution and neural networks are even like from nowadays. So it's this ability of being to just not use logistic regression, but having the whole like myriad of possibilities all in one, and also at the same time, as well as using like these neural algorithms, being also at the same time developing methodologies to apply them in the best possible way. For example, machine learning has introduced this idea of validation, right? Of splitting a derivation and a validation set to make sure that the modeling just goes in one arm and then you can validate in the other. Things that like weren't as much of a practice before, and are making these things even more reliable as time goes by. So it's the way forward, definitely, yes.
Thank you very much. Tony, I thought I might ask you just about the wider surgical team. So you've identified that in Hong Kong at present, things are relatively under control and your service is relatively controlled, but none of us know what the future holds.
That's right.
What I'm wondering is how we can use this to upskill ourselves, and looking at your wider surgical team, your junior doctors, do you think there's any benefit in creating some educational tools around this to prepare them for the future? Or do you think they would prefer some other learning technique, or do you think it's not needed at the moment?
Yes, I think first, congratulate Laura's excellent presentation. And I think with the collaborative, with the big data that we collected, it enables someone like Laura to interpret and gives us excellent results like this. But regarding at the moment, although it's controlled in Hong Kong, no one knows, as you know, new variants still keeps popping up. And in the future, it might not be COVID-19, it might be something else and so on. And so to have collaborative like this and collecting data so quickly allows an up-to-date analysis on what the current disease or current situation is, and allow us to spread the word. And I think with like a webinar like this, I will definitely go and tell my colleagues about this, and also say if there's like a 6th wave popping up in Hong Kong, and if the situation gets bad, we can definitely go into the Covidsurg. The online calculator is very easy to use, and then we'll get an opinion. I think it's more like an opinion, isn't it, for us to guide with our management. And if we see fit, then obviously we'll take the precautionary measures. Did I answer your question? Sorry.
You did. What I'm sort of also thinking is sitting in England, it strikes me that some parts of the world were better prepared for this than others. And so what I'm thinking is if we can take some of the information on VTE, some of the information around machine learning, create an online module that surgical members of the surgical team, junior doctors can complete and get certificates for, this might better prepare us for the future, because we certainly at my end have felt quite unprepared for everything that has happened, and we're catching up now. I'm not sure how you guys have felt about your response.
Yeah, I think so, because we had SARS, that's why when it kick-started, we were very cautious, and I think the whole population in Hong Kong were very cautious. And despite some corners in Hong Kong telling us not to wear a mask, actually everyone in Hong Kong wore a mask from start to the beginning, from the start till now. And so I think hopefully there won't be a next time, but if there is a next time, I think the rest of the world would be extremely careful and takes everything very seriously. And I think work like this will only help us rather than otherwise.
So I think, so thank you very much. I'm going to just begin to wrap up, and we'll finish a couple of minutes early. We'll launch a final poll based on the machine learning data. But what I'm taking for this is that we may end up having to make some difficult decisions around patients, especially in communities where the SARS-CoV2 rate has been quite high. We hope this data will begin to support that, but we are, as we mentioned last time, we are trying to create some online toolkits for people to look and take away this data. So we're going to launch that in a couple of weeks. So please make sure that you're signed up to the Covidsurg email list, and we'll circulate it through all our channels so that everyone in the wider surgical team can complete some CME CPD around the Covidsurg data. So that completes our double data release. We are planning, we don't have dates yet, but we're planning 2 other key data releases in the future. The first one is, and the analysis is undergoing at the moment, the effects of lockdowns on cancer surgery. So who did and didn't get their operation because of a lockdown. So that is going to be politically hot. I think it will allow us to immediately plan for the future, but not only the COVID future, the winter pressures future as well. When there are winter pressures, how are we going to ensure we have resilient services? Over the last few years, I was cancelling for increasingly longer periods of time over the winter months. And I think we all realize that this can't go on into the future, especially for our cancer patients. So for those of you who contributed to the Covidsurg cancer data, that will be coming out live soon, and we'll communicate with you on a webinar over that. And the second is we're going to put together all of our information around 10 key learning cases. So we'll build a diverse panel and we'll take you through 10 cases in how you can apply this data and take yourself toward a COVID secure service. But this leaves me to thank Elizabeth and Laura for their hard work and presentations, Manish for giving up part of his evening, and Tony for giving up part of his sleep to join us and give us some clinical context. So everyone take care. Please stay tuned for the next webinars. Stay tuned for the next papers. We'll communicate with you on Twitter, on our Facebook group, via email. And so please make sure you're signed up to those groups. Thank you very much, and thank you to the presenters. And good night and good morning to all our participants. Bye-bye.